I'm Joe Halko, Director of Community Relations for Northwestern Counseling and Support Services, and welcome to another episode of NCSS Here for You. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community have changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. We take our role in the community seriously and strive to provide a continuum of the highest quality services to meet the needs of individuals who at any point seek assistance. This month's episode is titled Integrative Psychiatry for Mood and Anxiety Disorders. This is the first of a series of programs that will address this subject. There are some individuals that don't respond well to traditional therapy for depression. However, many times there are nutritional reasons why therapy doesn't work for some people when treating for depression. To discuss the topic of integrative psychiatry for mood and anxiety disorders in greater detail, I'm pleased to introduce this month's guest, Dr. David Mooney, NCSS Medical Director. Dr. Mooney, I'd like to welcome you to the program.
Thank you, Joe. Nice to be here. Before we start, I want to bring up a disclaimer here. There's
Sure.
Disclaimers for everything.
Yes.
The slides that we're using today, the slides that the viewer will see,
Yes.
were not created by me.
Mm-hmm.
The slides were part of a presentation that Dr. James Greenblatt, who is the medical director of Walden Behavioral Health and one of the big pioneers in integrative medicine. These are his slides. Okay, so I'm using his slides, but I'm giving the talk.
Absolutely.
Yeah. So this is about integrative medicine, integrative psychiatry, and just to touch on that briefly, what that is. Integrative psychiatry is a complementary form of treating patients. We see many patients with refractory depression and illnesses like that need a different approach. I call it looking under the hood because it involves lots of labs and blood work, test tube psychiatry, whatever you want to call it, but it's an opportunity, which I'll talk about in a minute, about getting to the cause of illness. That's pretty much what it is. I also want to add that this is actually an exciting time for integrative medicine because last year, UC Irvine was granted a $200 million grant, which was the largest endowment that university had received for the study of integrative medicine.
Wow.
So my point is this field is growing. There's also, to be honest with you, there's also some backlash from some of our more traditional colleagues. However, with time, this is becoming the way to do things.
Don't you think also the backlash part? I mean, that is a very common thing because I think when you talk about evidence-based practices and all that type of thing, we continue to evolve in how we look at things and in looking at the whole person and that type of thing. So I guess what I'm saying is it's not surprising perhaps that there is some backlash from some who feel that this is the way it should be and the new model perhaps is not the way, but I think what you're suggesting is that over time, they will actually see that this is a way to get at the root causes and be able to help people even more.
Yeah, and we need to overlap what we do, especially in psychiatry. Again, I want to stress that point. This isn't just throw your medications away.
Sure.
This is working with in conjunction with what we already do. Yeah.
Okay, so let's start by talking about Larry.
So Larry's a real patient. Larry had depression for many, many years, 10 years, on all kinds of antidepressants. Every time he'd go off the antidepressants, he would get worse. He had cycles of depression and anxiety, barely functioning, didn't know what to do. He had many, many trials of antidepressants. Family history was notable for alcoholism, ADHD, bipolar disorder, all kinds of illnesses. And Larry tried the paleo diet, the inflammation-free diet, all kinds of nutritional approaches, and just wasn't getting any better. And so what happened to Larry? So Larry went to see an integrative medicine physician who put him on a boatload of supplements. I think the viewer will be able to see these. It's really, it's a shame that although you can appreciate this integrative physician's approach, it's a shame for anybody to end up on that many.
Sure, yeah.
Whether they're medications or supplements. So the point is, you know, we needn't go crazy with this either. Okay? And that brings me to our vitamin obsession. In fact, there was a book written about our vitamin obsession, Vitamania, by Catherine Price, which kind of talks about that we have indeed gotten obsessed with vitamins over the years.
And to some extent, I would imagine, you know, the vitamins have a place.
Oh, yes.
However, I think sometimes, as you're suggesting, is that people are on such a number of them. And I mean, in some instances, couldn't one counter another because there's so many different vitamins going into somebody's body?
Yeah, and that's why we try to do one thing at a time, too. I use vitamins every day. I would never use that many, of course. But you're absolutely right. Yeah, each one you add causes other reactions. Yeah, so we do try to keep it as simple as possible, and that's the whole point there. Just because there's supplements, you don't just go crazy with them either. Yeah. So basically, when we talk about depression, we talk about anxiety, we talk about neurotransmitter imbalances. What are the neurotransmitters? The neurotransmitters that we deal with in psychiatry are pretty much serotonin, norepinephrine, dopamine. Those are neurotransmitters. So we've been studying these for about 30 years, and we're trying to rationalize why they don't work. These deficiencies really are based on about a half dozen things here. Neurotransmitter imbalances can be genetic, you know, which would involve the synthesis of the neurotransmitters. Obviously, stress-induced, nutritional deficiencies can cause neurotransmitter imbalances. Inflammation is a big area now. Pharmaceutical companies are jumping on that. And of course, neurotoxins. Those can all be contributors to neurotransmitter imbalances. So all these processes have pathways. And for optimal neurotransmitter function and for the optimal production of neurotransmitters, there's a pathway that's really not that, well, it's much more complicated than how I'm going to explain it, but we need proteins from amino acids in our diet. There are 20 amino acids, 9 of them are essential, meaning we have to get them from our diet. And there are certain vitamins and minerals that we have to need as cofactors in this whole pathway toward neurotransmitters. We also need fatty acids and fats. Those are critical parts of the membranes of cells and help the cells work well. So my point is, we need these nutritional pieces for this whole pathway to lead us to optimal neurotransmitter functioning. And we need these cofactors like amino acids, vitamins, and minerals for that to work well. Okay? That's important for later. And of course, the daily macronutrients, I think most people know this: lipids, proteins, carbohydrates. Yeah. The micronutrients, of course, would be the vitamins and the minerals. If we're talking about depression, we need to talk about it in terms of the numbers. So depression is now the second most common cause of disability worldwide. Huge.
Which is extremely huge. And I know there are many who sometimes, once again, we get back to stigma.
Yeah.
Somebody who is depressed and yet for whatever reason, well, for stigma reasons, says, I'm not going to seek help. I'm going to deal with this on my own. And then as time goes on, they get into deeper and deeper depression. It makes it more difficult then to, of course, bring them back out of it.
Yeah.
But to your point, though, this is a huge problem.
In the next it's predicted that in the next 5 years, it will be the #1 cause of disability. So we're talking above, you know, cancer, heart disease. And if you think about how this impacts the younger people in our populations, I mean, look how many college kids go to, college health centers for help. How many, which I see every day, how many kids are seeing psychiatrists? Kids, 5 to whatever. So, yeah. And this last thing too, anxiety is 800 times more common than all causes of cancer. So that's huge. So the tragedy is that there's one death from suicide every 40 seconds. This 15-year study done by the CDC was recently updated, and when they updated that, they found out there has been a huge increase in suicides. There's been a 200% increase. We're talking about suicides, not attempts. 200% increase in the ages in females from 10 to 14. Yeah.
Again,
Yeah.
incredible numbers.
Yeah. Also, in anorexic patients, they tend to have the highest risk. Yeah, and that's because of nutritional deficiencies. You know, if you're starving your brain, it's hard to think right, and sometimes our thoughts go in directions we don't want them to. We used to say that, well, we don't worry about kids under 16 committing suicide, but that's not so anymore. We didn't not worry about them, you know what I'm saying? So I want to mention benzodiazepines. Benzodiazepines are Ativan, Valium, Klonopin, Xanax, drugs that are used for anxiety. They are very good for anxiety. That's the good news. The bad news is people get very dependent on them, and they're very hard to get off from. So I want to mention benzodiazepine overdoses because we hear about opiates,
Yes.
but this is very important too. So between 1996 and 2013, the rate of overdose deaths involving benzodiazepines increased more than fourfold. So that's a lot. And about a third of prescription drug overdoses are due to benzodiazepines. Important for the public to know this. Also, from 2000 to 2010, the number of admissions for substance abuse treatment and narcotic pain reliever abuse increased by 570%. So you say, well, maybe that's a good thing. People are getting treatment. Well, yeah. But
But it's the number that
Yeah.
we're talking about, the sheer number and the difference and the infrastructure, the system that you need to take care of all these
That's
people.
right, yeah.
Which is the other part of the puzzle as well.
Yeah. And the science, which is changing all the time too. Yeah. So when going back to polypharmacy, using lots of medications,
Yes.
there's 3 antidepressant medications we use all the time, along with others, but Zoloft, Prozac, and Paxlovid are ones that we use a lot, well known to people. I just mentioned those because those are ones that people tend to be familiar with. But the important thing here is that even with the best of treatment on antidepressants, 40% of patients relapse within 15 weeks. Okay? 20% are incapacitated or end up doing something to themselves, sometimes suicide, and then 66% have residual symptoms. So that's pretty easy math. That means that if 66% have residual symptoms, then 33% are, we hope, better. Okay, but that's only a third.
Right.
That's
now
only a
you
third.
Have the two-thirds that you need to continue to work with to try to figure out what's the path to help them achieve their ultimate goal.
With the understanding that only 1 in 3 are going to be symptomatic or have their depression adequately treated. So it's like if we look at primary care, if in primary care, if a third of the coughs got better, it wouldn't be very good, would it?
That's correct.
I mean, would that be
Correct.
acceptable? It wouldn't be acceptable to,
Right.
You know what I'm saying?
Yes, I do.
Yeah.
People would say that if that's the only percent, then well, what do we need to do differently to address the other 2/3? And they would really be on that.
Yeah.
And the funds to study that, what have you, would be significantly greater than what we're talking about.
Yeah.
In this part of healthcare.
That's a different pail of money too. You know, in integrative medicine, it's hard to get money. It's hard to do studies, research studies on broccoli and get that funded. But you could probably get some drug funded.
Right, right.
You know. Anyways, I digress. So, but we do have to use the approach to medicine that our internal medicine colleagues are using, which is to look at the symptoms, measure the physiology, which that's what I'm talking about with integrative medicine, measuring things, getting labs, and we need to cross over. Psychiatry needs to cross over into medicine more and get more objective testing done. Over the years, I think we've done a pretty good job, but you'll have to admit that we've been slow to make progress in psychiatry because this is how we work. We talk.
Yes.
And that's great, and we get histories. We don't do objective testing, and you're sad. I meet with you, you're sad, I give you a sad pill, so.
Yes.
Yeah. There is a group of people that have gone the other way, really anti-psychiatry. That's really too bad because it's not all or one.
Yes.
All or nothing, I'm sorry.
Nothing, yeah.
All or nothing. Because it's not like all we do is just give people drugs. That's not what psychiatry is about. So there are some people that have gotten a little carried away with the anti-psychiatry movement.
And don't you think also, Doctor, that is it is misunderstood, that the minute you say, well, perhaps we should have you see our psychiatrist, that the wheels spin, and the first thing that comes to mind is, I'm just going to be given a 30-day amount of some kind of a drug.
Yeah.
Not looking at the whole picture when you talk about treatment and a critical aspect, which is, like you say, what we're doing, which is the communication and the talking portion of the treatment. And you work that together with a potential medication.
Right.
It's meds only. And in fact, I think people would be very surprised to know how few individuals that we see at NCSS who actually are on medications.
Yeah.
It's a very small percentage.
Right.
But that is not what the outside world perhaps would think.
Right. And what they also need to know that in general, our approach is to not just put you right on medicine. Our approach, I tell patients all the time, I say, yes, we're giving you this medication, and I think this medication will help you, but you need to know that we're giving you this medication because the hope is that at some time you won't be on medicine. This medication is a bridge to no medicine.
Yes.
Yeah.
Yeah.
Yeah. Since these are Dr. Greenblatt's slides, I think I should give him some credit with his zebra approach, which is actually a very good approach to depression and anxiety. Dr. Greenblatt refers to this as a zebra approach because if you think about zebras, each zebra has unique stripes. There are no two zebras the same. And the idea behind the zebra approach is to approach patients differently, each patient differently biochemically. So basically the zebra approach, the T is for, well, take care of yourself. We all know about that. Get the right amount of sleep, avoid stress. Hormones involve the major hormones that we like to look at are thyroid hormone, adrenal hormones, sometimes sex hormones like testosterone, low testosterone, very common in men as they age. E for exclude, that would be excluding food allergies, primarily like things like celiac. Zinc, goes back to my slide earlier, you need zinc and other minerals, especially magnesium, even lithium, nutritional lithium. Lithium is in our water, not as much as it used to be, but we need zinc and other minerals. We need essential fatty acids. Those are the omega-3s, and that goes back to what I said previously about the fatty acid components, the fatty acids being components of the cellular membrane, and exercise and energy, we all know about that. B vitamins, B12, common cause of depression, or contributing factor to depression, not the cause, but contributing factor to depression. That's often low. So people often need B complex supplements. Restore, that involves the gut primarily. Big probiotics is a big area right now. That's a whole nother talk, but we can restore the gut with probiotics. And then what we're talking about today, amino acids and proteins, which are very critical for the in that whole neurotransmitter pathway. But this isn't just about getting labs. This, obviously, you need to be treating the person that's sitting across from you. It's not just looking at lab results. And there are many ways to test: urine test, hair test, blood test, saliva, all those. Wanted to bring up junk food and depression. We all know that.
Yes, but I think it needs to be discussed
Yeah.
because it's one of those things, you know it, but yet.
Yeah, and we all know that. But we don't think of that. We don't think of when we think of fast food. If I asked you, what happens when you eat a lot of fast food, you would probably say, well, my cholesterol would be high. I'd be at risk for a stroke. I might have a heart attack. You wouldn't think, well, I probably good chance I get depressed.
Correct. Yeah, that's right. All the discussion is always centered around all the other bad elements that one thinks about when you're consuming all those fast foods.
Yeah. So just some numbers on that. 9,000 people that were not diagnosed with depression were given fast food and processed baked goods. Okay? And then you got a group that you don't do that with. That's the control group. You don't give them the processed food and all that. So there was a 51% greater chance of developing depression in those that ate the junk food. No surprise there. I'm surprised it's not higher, actually. But just so people know that there are people doing studies on this.
Yes.
And this happened to be a 6-year study. So, let's see.
So now, when you do talk about diet and depression.
So there are studies on that. Dietary recommendations for the prevention of depression. I've listed that one. There's a particular trial I would refer people to, which is the SMILES trial. It's a study of dietary improvement for adults with major depression. Just wanted people to know that was available for their review. Also, when we give dietary support and we give social support, we also know that depression obviously improves. There's charts that show the results of that. Also, this is not just improvement, this is a remission of their symptoms too, so that needs to be pointed out. We talked about Larry. I just want to talk about Marcia a little bit. Marcia's a different patient. This is really important stuff. So Marcia, all the labs were done at the time of admission, and they were all normal. Marcia was depressed. She did everything right. She had her, salmon flown in from Alaska and ate organic, and the perfect patient, and did everything wrong, but she was depressed, and her labs were normal. So the psychiatrist says, well, let me see. Why don't we give you some Lexapro? I have some samples here. Okay. That was back when psychiatrists had samples. Fortunately, we don't now. That's changed for the better. So doctor gave her some Lexapro. She comes back 2 weeks later. She's not feeling any better. She's agitated. She's not sleeping. So the psychiatrist says, how about if I add some Abilify, which is relatively new around that time too. That's a mood stabilizer. She said, well, because he wanted to control the mood. Okay, now she's on 2 medications. She comes back 2 weeks later, still symptomatic. Psychiatrist starts her on Wellbutrin, because that's a different class of antidepressant, and throws in some Lamictal. So now, for mood stabilization, it's a month and she's been on 4 new medications. The point is that sometimes it's easier for people to add than to take away. And often when we do that, we're just getting further and further in a hole. So she's been on all these trials and all that, so now what do you do? what's recommended in integrative psychiatry now at this step, patients not responding to anything, we've done just about everything, is to draw fasting serum amino acids. Because if we go back to that chart, amino acids were involved in that pathway. And this is one of the most helpful tests when people present with fatigue, depression, anxiety. And when you get serum amino acids, that it doesn't measure their intake. Like if they just ate a steak the night before, would your amino acids be high? It doesn't measure intake. It measures how you metabolize amino acids. Okay. So the point is that if their amino acids are low, then that whole pathway is kind of shut down at that point. Okay. It doesn't get to the neurotransmitter point where we need to be.
Okay. Yep.
Okay. So Marcia's amino acids are low. So what do we do? Well, if her amino acids are low, that means she's not breaking down that fancy salmon from Alaska. So, okay, because we know that she's doing everything right, but her amino acids are low. So, okay, so what do we go to now? Well, you can add amino acid supplements. That's quick and easy. This goes back to Larry. Could have done the same thing with Larry, gotten a test for fasting amino acids. These are people who don't digest and absorb amino acids well. So we do that with both patients. Test for amino acids, but for there not to be any amino acids, that means that it's highly likely that they also have low hydrochloric acid in their stomach, because you need the hydrochloric acid to break down amino acids for this whole process. So if patients are taking like Prilosec, Pepsid, all these anti-acid over-the-counter,
Yes.
or proton pump inhibitors, it's possible because they're on those that their their stomach acid level is low, and so that's not good because they're not going to be able to break down. They're not getting the amino acids. They're not able to break down proteins into amino acids for this pathway towards the neurotransmitters. So sometimes people who are under lots of stress, they'll have low levels of hydrochloric acid. So that needs to be, the treatment for this would be, if people aren't breaking down proteins into amino acids, the treatment would be to add amino acids, but to also, there even is, at times, people need supplementation with hydrochloric acid. Obviously, I don't want people running out and stopping their Nexium tomorrow because of what we just talked about.
Right.
But the whole point of this is that if people are not responding to medication, they're still depressed, they've done everything perfectly, we need to dig a little bit deeper. We need to look at the blood. We need to know what's in there and what isn't in there. Because it's not, well, you're treatment refractive, I don't know what we're going to do now. It's an exaggerated response, but you know what I mean?
Okay, sure.
So we need to look at things like amino acids, and we need to look at things like fats. So that's the whole gist of it. Yeah.
So basically, you're saying times are changing.
Times are changing. Times are changing, and there's things that we can do to enhance people's ability to feel better. Yeah.
And I think with that, Doctor, as we said when we began this segment, this is the first of a multi-part series to get a full understanding. And this will close out this segment. And, we'll be back to further delve into this subject matter in a couple of months. And hopefully the viewer will get a better understanding of a lot of this. And if they need to seek the treatment that they need.
That's right.
So I want to thank you for being on the show today, Dr.
Thank you. Appreciate it.
I also want to thank you, the viewer, for spending time with us again this month. You can learn more about NCSS programs and the services that we provide by logging on to ncssinc.org. I'm Joe Halko, and I'll be back next month with another episode of NCSS here for you.